Good evening, friends. At the onset, I'd like to thank Shishir and Dr. Umapati for inviting me here. And I'll be talking to you over the next few minutes about recurrent glomerulonephritis post-transplant. Right. Okay. So, this is, I think, one of the most challenging case scenarios that we see. When I started my practice nearly 3 decades ago, whenever I used to see these patients coming to us with recurrence, I was reminded of this quote by Voltaire, who he was a French philosopher who used to best doctors. And he said that doctors are men who prescribe medicines of which they know little, to cure diseases of which they know less, in human beings of whom they know nothing. So, you treat glomerular, you don't know why glomerulonephritis occurred, you treat them with steroids, you treat them with tacrolimus or whatever you have, and then the patient comes to the end of the road and you give them a rosy picture of a transplant, and then when the disease recurs, you really cut a sorry figure. You don't know why, what was the mechanism in the first place. But over the last 3 decades, I think there have been significant advances to the understanding, and I'll take you through that. So, glomerulonephritis is the cause of PSRD in 30 to 50% of our kidney transplant patients, and more common certainly in children. Kidney transplant following primary GN generally enjoys good graft patient and graft survivors. There's a 10 to 20% recurrence of patients with glomerulonephritis, but half of them will lose their graft on long term. And this is from the ANZ data. Recurrence in their series accounted for about 10% of all patients, and usually due to primary glomerulonephritis is the IGA, FSGA, membranous, or they called it mesenteric, which we call C3, or then we call it living, generally late after 28 years. So late graft loss is one of the leading causes we all know of end-stage kidney disease, and here recurrent glomerulonephritis is the third important cause of graft loss in the long-term follow-up. So as the duration of the graft increases, the recurrent glomerulonephritis becomes more important, and risk factors were largely unknown or imprecise, and prediction remains difficult, although there have been improvements. So this is what I was telling you, that at 10 years, after chronic rejection and death with a functioning graft, recurrent glomerulonephritis is probably the most common cause of graft loss. Now, what are the challenges in the diagnosis of recurrent glomerulonephritis? First of all, there is a lack of unified approach in diagnosing patients with post-transplant proteinuria, hematuria, renal dysfunction, non-uniform indications for biopsy. Immunofluorescence and electron microscopy are not routinely performed in transplant biopsies, and many of them have not had kidney biopsies of the native disease. So there are also difficulties in differentiating mesenteric and chronic allograft nephropathy. So these are the important glomerular diseases. Mind you, there are certain non-glomerular diseases like primary hyperalbuminuria and cystinosis. I will not touch because of constraints of time. But predominantly, the glomerular diseases you need to worry about are FSGS, C3GN, atypical HUS, IGA, and membranous, and then to a lesser extent lupus, anti-GBM, and possibly. And these are the risks of recurrence and graft failure. If you look at IGA, 50 to 60% of histological recurrence, 70 to 30% of clinical recurrence, and I think we are diagnosing now more and more of this IGA recurrence, probably because we have become more aggressive with our biopsies, and the graft failure is something to keep in mind, as high as 20%. But again, it's slow. FSGS, I think, is one of the most vulnerable diseases, 20 to 40% recurrence and 20 to 27% graft failure. Membranous 10 to 40% recurrence, 20 to 50% graft failure. And this is mesenteric type 1, type 2, now we call it C3GN, monoclonal related, very high recurrence rates. ANCA is, I think, relatively less common. SAB remains an issue, 14.3% graft failure. Anti-GM, I think, GBM is perhaps the mildest of the lot. Fibrillary and immunotactoid, more than 50% recurrence, but the anecdotal cases are there. We are not sure what will be graft failure. So these are the recurrence rates for primary glomerulonephritis if you extend it to 5 years and 10 years. FSGS, what happens is most of it is early recurrence, and thereafter it plateaus. As you can see, 6.3 at 5 years and near the same 8.7% at 10 years. IGA definitely, as the time passes, it becomes more of an issue. So as our patients are surviving longer, we are picking more and more of IGA now. Mesenteric again, very early recurrence. Membranous nephropathy again, relatively later recurrence. So the timing of recurrence also, tells you something about the underlying cause. And these are the KDIGO guidelines. I think the newer ones should be out soon, but we're starting the old ones. So they suggest screening kidney transplant recipients with potentially treatable recurrence of primary kidney disease in the IGA, NPGA, and NTPDM, or anti-acute vasculitis or microhematuria, once in a month to determine a baseline, every 3 months during the first year and annually thereafter. Now, many times it's a challenge as to whether the proteinuria is coming from the native kidneys, or is it a recurrence of disease. And this is an excellent study by Rankin et al., published in the American Journal of Transplantation 2005. And what they found was that resolution of native proteinuria occurred in all patients at a mean of around 4.5 weeks post-transplant, with a range of 1 to 10 weeks. If you find proteinuria, if you have transplanted a native patient, you find that proteinuria is not recurrence, maybe coming from the native kidneys. But yes, if you start quantifying it, following, that will be helpful in telling you that whether it's coming from the native kidneys or is it a recurrence. And this is what the KDIGO guidelines suggest. That we suggest plasma exchange if the biopsy shows minimal changes in your FSGS in those with primary FSGS, which suggests high dose corticosteroid and cyclophosphamide in patients with recurrent ANCA or NTGBM, and ACE or inhibitor or ARBs for patients with recurrent glomerulonephritis and proteinuria. Now, what about FSGS, which is really the bugbear? So, recurrence rates after transplant vary from anywhere between 30 to 60%. And this is because of variability in the study size, study design, the criteria used. And the pathogenesis of recurrent FSGS largely is unknown, although the presence of a circulating factor toxic to podocytes is highly suggestive. Now, these are patients of FSGS who have a low risk of recurrence for all genetic causes except NPHS1 mutations with the same major type, which is a recurrence rate of anywhere between 25 to 34%. And if the patient previously had subnephrotic proteinuria. Again, FSGS without clinico-pathological signs of secondary FSGS and no nephrotic syndrome representation, that is, I'm talking about the history. So, even if he had a label of primary FSGS, but it was not nephrotic, more likely secondary FSGS, these are the patients who are less likely to recur. Now, next we look at this question: should patients with primary FSGS undergo genetic testing before kidney transplant? Well, genetic testing should be considered an important tool for the risk stratification of FSGS because now we have excellent markers available. And studies of FSGS recurrence in patients with monogenic or familial FSGS have revealed a low risk recurrence rate as low as 0% in the pediatric cohort. So if you picked up a gene mutation, in a native disease, a native FSGS, you have to withdraw immunosuppression, but you can tell the family that at least once they undergo a transplant, the risk of recurrence is minimal. Now, next question in FSGS is: should patients with primary FSGS undergo prophylactic treatment around kidney transplantation? And the answer is that no study has found a significant effect or benefit effect of plasmapheresis on recurrent FSGS. There is no role. Surveillance after kidney transplant with initial daily proteinuria measurements is recommended, and there are ongoing trials with preemptive use of rituximab, looking at the monoclonal anti-glazulomab or ACTH on recurrent FSGS. So no point in doing any preemptive plasmapheresis. Now, next dilemma is that should these patients undergo native nephrectomy post-transplant? That is, prevent post-transplant FSGS? The answer is again no. The only exception could be that in children where native refractory hypoalbuminemia and continuous requirement of intravenous albumin administration is required. The child is so nephrotic, the life is miserable, probably as the one as was shown in the earlier case. Now, in adults, in fact, it has been shown that native nephrectomies have been associated with higher risk of FSGS recurrence and have been abandoned by most centers. So, patients with risk of recurrence should be monitored with daily measurements of proteinuria for the first 1 to 2 weeks after kidney transplant, after which the frequency of measurements can be slowly tapered as terminal. Next, we try to look at which is the best treatment for patients with recurrent FSGS after kidney transplantation. So, you have picked up recurrence, you have proven it with a biopsy, and so plasmapheresis, no doubt, remains the best form of therapy, sometimes combined with rituximab, because atherosclerosis produced with circulating factor, where rituximab may act as a direct effect on podocytes or by its depletion on immune B cells. Immunoadsorption has been used, more selective removal of immunoglobulin with the advantage that no substitute fluid is required and no coagulation factors are lost. And in patients who do not respond to flex or rituximab, LDL atherosclerosis, abatacept, ACTH-gel, and adalimumab. But I have anecdotal experience with this monotherapy with rituximab without plasmapheresis also, where because of financial constraints we could not do plasmapheresis, and some of these patients did work in the complete condition. The next question is, should patients with previous graft loss due to FSGS recurrence be considered for another kidney transplant? So in patients with previous graft loss due to recurrent FSGS, the risk of recurrence increases to 80% in the second and almost nearly 100% in the third graft. So these patients, should be, offered a cadaveric transplant, and there should be no point in losing another life. Next we switch gears and we talk about atypical issues. So recurrence of atypical issues occurs in anywhere between 20 to 100% of patients, strongly influenced by the genetic background. And patients with mutations in the complement factor genes have a threefold risk of recurrence compared with other people. So genetic complement testing should be performed in all patients with issues who are planning for a kidney transplant. And the KDO controversy conference recommends actually starting prophylactic infliximab at the time of transplantation. I'll tell you how to stratify these. But these are the subtypes. So factor H mutation, there is a 66 to 76% chance of recurrence, and majority 77 to 93% would lose their graft. Factor I gene mutation, 88% risk of recurrence, 100% would lose their graft after 1 year. Factor B or C3, slightly lower risk of recurrence. MCP mutations are the mildest of the lot, less than 20% recurrence. ADAMTRIS 13 deficiency recurrence is frequent, FFP can be given. And this is a slide which tells you how to stratify or choose prophylactic infliximab. So in patients who have high risk of recurrence, they may be 50 to 100%. Like previous early recurrence of atypical HUS, pathogenic mutation in the HUS gene, or gain of function mutation, it is mandatory to use prophylactic infliximab. So there is a moderate risk. No mutation has been identified, or there is an isolated mutation in CF1, or variant of uncertain significance is there in the complement gene. Prophylactic infliximab or plasma exchange is recommended. And only when you have a low risk, as I mentioned, isolated MCP mutation or persistently negative anti-FS antibodies, you do not use the prophylactic. Next, we move on to CPGL, and recurrent disease is seen in anywhere between 65 to 85% of patients with a median time of recurrence of 14 to 28 months. Again, genetic and functional complement testing should be done before transplant in all these patients. And as far as the treatment is concerned, close rate of allograft loss was 33% despite use of infliximab, 42% despite infliximab, and 81% with infliximab. So very high rates of graft loss, and I think we should be having infliximab if you are doing such treatment. The infliximab was associated with lowest risk rates of recurrence in C3 glomerulonephritis, 22% versus 56% if you use plasma exchange, or 70% if you use rituximab. With limited data for death repository disease, where there was a 53% rate of allograft loss despite use of infliximab. So, counseling is very important prior to transplant when you are picking up certain patients. Again, saying this, we just transplanted about a couple of months back one patient with C3GN who could not afford infliximab, and we gave rituximab again after adequate counseling. We also monitored her closely, did a protocol biopsy at 1 month post-transplant, which is fine, and she's now currently 3 months doing it. IGA nephropathy, and I think this is becoming a bugbear, as most of us would agree with it. Recurrence rates 10 to 30% in various studies for all cause biopsies, and 25 to 53% in patients with protocol biopsies. And recurrence of IGA doesn't seem to have effect on the short-term graft survival, although in some studies with longer follow-up, graft outcomes are definitely worse with patients without, as if you compare them to patients without recurrence. Again, histological recurrence is there in 50 to 60% of patients with IGA, 30% in HSP. Clinical recurrence is one-third. Recurrence in one study which used ATG, recurrence was lower if you had used ATG induction and if you are doing MMF versus ASA. Again, rapidly progressive glomerulonephritis as a cause of end-stage kidney disease. If you have there is a very high risk of blood clot and fulminant IGA post-transplant. Lower risk is there in patients with mesangial lesions with cirrhosis and urine donors. And as far as treatment is concerned, ACE asks, budesonide, you could try based on whatever, but there are no good long-term trials. And rituximab has been used in anecdote. Now, should early steroid withdrawal be avoided in patients who have been transplanted and have kidney failure due to IGA nephropathy? And avoid early steroid withdrawal because few studies comment on the possible association between early steroid withdrawal and recurrent IGA nephropathy. However, the Tango study, early steroid withdrawal was prescribed in 76 out of the 504 patients with native IGA, and there was not reported recurrence of IGA after transplant and multivariate analysis. But newer trials are required to investigate the association between steroid withdrawal and recurrent IGA. Thus, membranous nephropathy, the recurrence rate is 10 to 30%, and de novo membranous can also occur in 10% of the transplants. Recurrence is about 20 to 40% with anti-PLA2R antibodies at 2 years. Patients with recurrence after transplant and those with gastric progress rapidly towards heart failure. You can use ACE, ARBs, and rituximab certainly now a standard of care in such patients. Now, how can PLA2R testing be used to improve the management of patients with membranous nephropathy in the transplant setting? And detectable PLA2R antibodies before transplant have been significantly associated with the recurrent membranous nephropathy with a hazard risk of 3.76. Persistent or re-emerging PLA2R is also associated with an increase of proteinuria and in some patients with resistant. A word about lupus nephritis. Histological recurrence has been reported in about one-third of transplant patients. Clinically significant recurrence in about 2 to 9% of these patients. Rare in pediatric transplants. Most common histology is mesangial lupus. Blood clot is uncommon, and postponed renal transplantation until the disease is present for at least 6 to 9 months. We had one patient who had recurred and we used rituximab with quite satisfying results. Autoimmune glomerulonephritis. Recurrence in about 15 to 17% of patients. No difference in the relapse risk between patients with circulating ANCA, those without circulating ANCA at the time of transplant. And relapse rate is higher for vectors as compared to other autoimmune glomerulonephritis. And treatment is plasmapheresis, cyclophosphamide, glucocorticoids. Rituximab is another emerging modality in these cases. Anti-GBM nephritis, again, recurrence when there is a high level of circulating antibodies prior to transplant, and reappearance of anti-GBM antibody in the serum may be associated with histological recurrence in 50% of patients with clinical manifestation less than 25. Blood loss is there, and the standard recommendations are to defer transplant if possible until the disease is quiescent and circulating anti-GBM antibody detectable for at least 12 months or minimum 6 months. And what a point to keep in mind is that de novo anti-GBM can be seen in about 3 to 4% of patients where Albert is disease. So I conclude that primary glomerulonephritis recurs in about 10 to 16% of the anemia allografts over a 15-year period. FSGS and CPGN tend to recur earlier than IGA. These are the three ones you will keep in mind, followed by membranous. After recurrence, graft survival is significantly reduced. Transplants performed after a previous recurrence have similar risk of recurrence, except for FSGS, which is far more likely to recur. And there is limited understanding of the immunobiology and physiology of most glomerulonephritis, which has hindered the diagnostic and therapeutic innovation. And patients as well as clinicians need to be aware of the risk of the recurrence and its consequences, and we should counsel them in the transplant. Thank you, sir.
So thank you, Dr. Gulati, for an excellent presentation, and the questions open to ask.
Excellent talk once again, and as you rightly pointed out, these topics are very interesting and different for post-transplant. We had a couple of challenging issues. Some people do say that using oral galactose might help with children prophylactically also. We ourselves had a very challenging case. In fact, we traveled all the way to Delhi. We was advised IGA Nephropathy. But after transplant, we treated him with rituximab and cyclosporine. That seems to help as compared to that. And he right now is in complete remission. So that's one direct case. The other question is, he did have a myoglobin mutation. So does that have any implication on what happens in later? Will anybody develop anti-myoglobin antibodies?
Not to the best of my knowledge, but I would vouch for that. There are certain patients who respond to just rituximab also, as I said, with more out of, although you should and you would advise plasmapheresis. I think that is where it is literally the standard of care. But if for some reason you cannot do that, even if you just give rituximab, I have got now about a 7-year follow-up of one such patient who didn't relapse to this case because they didn't have enough money and yes, changing to cyclosporine, again, there are studies, anecdotal reports where cyclosporine we could use, although tacrolimus is supposed to be far more, immunosuppressive, much higher effect, and galactose, I'm not personally aware of any.
Gulati,
Yeah.
this information is not responsible. And
Not responded to?
not responsible to treatment based on that. And usually after 3 months we stop immunosuppression, and after 6 months we find this patient still have positive antibodies. Would you go for transplant?
No, I would wait. I would counsel against transplant. We have one such patient who is just cleared now after literally, I think he's about 7 months. But for 6 months, he came to me. I said that
It's positive because this patient is immune. The kidneys are wrong. There is no symptoms or symptoms of disease activity. So just for the
there is a high risk of recurrence in these patients. That is what it is. I'm not aware of if somebody has gone ahead in these patients.
Is there a role of combined liver and kidney transplantation in atypical HUS?
In atypical HUS?
Combined liver and kidney.
Yeah. But now you have eculizumab available, now. Cheaper than combined liver kidney. Eculizumab incidentally is available. You can, now you have agencies which will get eculizumab. You just have to be willing to pay for it. For transplant, pre-transplant, yeah, definitely. It's just costs about 20,000 or so, even in the corporate sector. I think the guidelines are clear that because again C3GN interestingly also has got a phenotypic overlap with atypical HUS. If you see, in fact, I think one of the current issue of No, there is, if you read the latest IGA, Vishwanath from Bangalore has reported where, C3GN presented as an atypical HUS post-transplant is used eculizumab. Native kidney, I have seen that. We had a biopsy-proven case of mesenteric glomerulonephritis diagnosed at another center. And years later presented to us with classical atypical HUS, ended up with. Yeah, that's what I'm saying. We have seen these patients and we managed, I think, Alti would remember. And interestingly, this child responded, we didn't have eculizumab, so we used rituximab and he became dialysis free.
There are 7 cases in the world of patients who started with C3GN and at some time either pre-transplant or post-transplant.
One patient, 2 diseases, 3 kidneys, 2 diseases, something like that.
I think it was one CPC, I still remember, Ahmedabad, we had the Indian Society of Nephrology Conference, CPC. It was an identical case. who had a C3G and yeah, I think from PGI. The case was from PGI, if I'm not mistaken, years back.